All right, well, thanks very much, Roseanne. It really is an honor to be here. I appreciate the invitation. This is a topic that I'm really interested in and hope to share with you some of the thoughts I have about motivation, which, as you say, I suspect a lot of people are very familiar with this issue. A lot of people have probably come up with their own strategies for dealing with it. I may not say a lot of breakthrough stuff, but I hope to reframe things in a way that might make it it's just sort of different, a little bit unique in terms of how you think about approaching learners. So actually, this is a slide I got from doing a image search of unmotivated medical student. So that was my image search term, and this is what I got. I imagine he's checking his watch because he's got somewhere else to go, and he's tired of being in clinic. I don't know. There were a few other unmotivated medical student slides from preclinical years of people sleeping on books, so that was kind of fun. But I'm probably going to focus a little bit more on clinical learners, because I think that's where this issue comes up. We face it more directly. Everybody can see this okay, by the way? Okay. So for starters, let me just mention, because I think this comes up for a lot of different kinds of learners. I got an email the other day. Your annual training will expire in 30 days. You have to complete these steps to really learn about UPMC's Information Privacy and Security Awareness Training. So does anybody else get these sorts of emails? No, we don't. Okay, well, a bunch of us do. And so I'm wondering, when you get this email, how enthusiastic are you to click on these links and to get started on this training? How many of you are jumping at the bit? You really love this stuff. I was not motivated either. So what's up with that? How come we're not motivated learners? We're supposed to be in academia. We want to learn. We have the thirst, the intrinsic quest for knowledge. How come we weren't motivated for this?
I would argue because this doesn't impact our day-to-day practice or whatever we do. It's not important.
Yeah, relevance is really low for many of us, okay? Other reasons why?
I don't perceive this as a learning experience.
It's training, not learning, that sort of thing?
It's a chore.
It's a chore. You got to do it. It's not as much fun. Yeah, it's not something. Okay, any other reasons?
We did it last year.
Did it last year.
The year before.
Yeah.
The year before.
And you know what gets me also is the quality of these trainings. I don't know if what your impression on it. They're not all high quality, let's just put it that way. And so I feel demotivated every time I get these links. And it gives me empathy, I think, for a lot of medical student reaction to some of the things that we do, that we think are important. Because I know that there are people at UPMC who think this stuff is really important and interesting. So hopefully this, right? Hopefully this will help you. So we'll think about, how come we're so unmotivated? What is going on here? What I would like to do is to, by the end of the session, help you guys assess what's going on with learners who appear to be unmotivated. We'll talk about common motivators and barriers for learners, things that they face that get in the way. And then we'll try to apply some basic psychological principles and strategies that may enhance learner motivation. Nothing too out there, some basic stuff that I think could be useful. All right, so this is the outline or the overview of what I want to do. I want to talk about a case. We'll talk about teacher-learner factors, motivators and barriers. What I want to introduce a little bit is motivational interviewing and the trans-theoretical stages of change model that I think can inform this process of motivation just a little bit. We'll put it all together with some basic strategies, and we'll try to apply those in a couple of cases. There are some challenges we'll get to towards the end, and then we'll wrap up. So that's the outline. First, a case. Okay, and this is a real medical student case. I talked about this at the last retention committee meeting. I had a third year in clinic with me on the psychiatry portion of the clerkship, and we were seeing a 45-year-old woman, new onset psychotic symptoms. She had a history of epilepsy and head injury, a lot of physical abuse, sexual abuse in her history, a family history of weird movement problems in relatives, and a couple people who died young. And so I was like all over this, like, this is really interesting. What is going on here? What does she have? And so I asked the medical student, hey, do you want to interview the patient? Let's find out what's going on. And the student said, no, that's okay. Thanks, but no thanks. And I was floored. It's like, what is going on? And so I was really trying to think about this. Is this okay or not okay for a learner to opt out like that, to appear Because it really appeared like this person really just didn't want to be there, wanted to get out of there, and I'm, you know, and so I was thinking, okay, maybe it's okay. And so I wonder, are there reasons, if you had a learner like this, that you would think, well, maybe it's okay for them to opt out like that? What do you think? No. Okay, so you want to answer the other side, like what the heck is going on?
I think it's absolutely okay to opt out sometimes. I don't always bring my A game. I don't expect everybody else to always bring their A game.
Yeah.
Things in my personality.
So what would get in the way of this third-year med student?
Only really serious stuff, but especially where one is relative or something like that.
Okay. So if the person was a family member, maybe it wouldn't be appropriate. But what about Greg's thought about things that might get in the way for the med student? What would get in the way?
As I see it, you already have so much knowledge that you recognize this as an interesting case.
Yeah.
You're also a psychiatrist.
Yes.
And this person may not want to go into psychiatry. They may not have enough knowledge to recognize what are the interesting features of this case. And you're just looking at it from different perspectives. They may have something they need to go do.
Yes. Yeah, what do you think?
I think we're accountable as physicians to pick up perhaps lethal diagnoses and work them up, regardless of our specialty.
Yeah.
So it really doesn't matter how you feel. There's sometimes, if something, if you're an MS3, you already know this what the differential will include a lethal diagnosis.
Mm-hmm. You've got to do it. Yeah.
There's also the possibility that the student herself had some of the same things and it got captured.
Yes, yes. And students do have these things in their personal family histories that could interfere with their, willingness, comfort level with some of that. What do you think?
So, I mean, the first question I'd ask is there some reason you don't want to see this patient? Try to get at that. But, and then the other thing is, with duty hours and cabs and all that kind of stuff that they see in the resident, you wonder is, you offered the option. Is this like an extra admission? Is it
right.
a return?
Yes, yes.
You know what I mean? That whole kind of thing.
There are a lot of things that could get in the way. And so I think we've outlined a few of these, and this was some of the lists that I came up with. So going into radiology was one thing. It turned out actually it was a brand new third year, so that they had just finished taking their boards, and now they're thrown in. Maybe they have other things to do. This is the first session in the clinic. They were on call last night. I think actually for this particular student, there were also a personality style that made them come across in a certain way, even when they may not have been that way. So I was trying to rationalize this, and think about it. But then the other side of me, as you guys were also thinking, he's got to learn this stuff. It's leaving a bad impression on me. This is fun. It's also my responsibility to teach this student, and so I really was torn about what to do and how to think about it. And I think this also gets to this idea that there are motivators and barriers, there are things that get in the way, and there are things that we should do to try to enhance learning.
I would
Yeah.
add one thing to that list, which was the student's responsibility to learn. It's not just your responsibility.
Yes, absolutely, and that's definitely on the other side. We're going to come back to that.
I think one interesting thing about the interaction was that you gave him an option that you didn't really feel comfortable with, and then he took it.
Yes, actually, yeah. My wife brought that up when I told her this story. She said, don't ask the student, tell the student. Anyway, so we're going to think about how we might have handled this, or you might have done it differently, or once the student says this, now what do you do? And we'll come back to it a little bit later after we explore this construct of motivation a little bit further. So next I want to go to the teacher and learner factors that can get in the way and identifying motivators and barriers. So if this is our teacher and learner dyad here in a clinical setting particularly, what we want to do is make a differential diagnosis, basically. When we get what appears to be an unmotivated learner, someone who's not really connecting with us, we want to know what's going on. And I think there are a number of factors that could get in the way. One, as we've touched on a little bit, is the issue of barriers. That there may be, for the learner, there are things that are interfering with their ability to process this. There's also factors in the teacher, that things that we could do or maybe we didn't do that would have made it easier. A personality mismatch, which we alluded to, and the possibility of impairment in the learner. So there's something going on with the learner that is getting in the way. So we want to tackle a bunch of these over the course of the time. But first, I want to get to the teacher issue, because we don't often think about this. We usually blame the learner. We say it's their fault for not being motivated, when I think sometimes it may be things that we're doing or not doing that are getting in the way. When I asked Jamie, too, about this, everybody knows Jamie, he had a real conniption about this. He's like, this unmotivated learner stuff is a load of crap. It's not about the student, it's about us. When we've got an unmotivated student, we tune out because it's demoralizing and tiring. We lose enthusiasm and end up interacting less with them. It's a self-fulfilling prophecy. Because at the mid-course, we criticize them for not doing things they think they should have done. We think they should have done, but we never told them about or never helped them to do in the first place. Right? So this really opened my eyes to this idea that it's about us as much as it is about them. Okay? So I think there are a number of issues that can affect what we do as students. We get disengaged. We judge the students. Who are they? We expect too much from them, perhaps. We expect learners to be on their A game every single day they're in medical school. And that's not realistic. I'm not on my A game every single day. And so I think that may be an issue. We often try to go solo on these things, try to handle it all ourselves, when actually getting help could be useful for everyone. The personality issues, there may be a mismatch. And then in terms of how we teach, if there are deficits in the teacher, that could get in the way of the learner, of course. All right? So that's one side of this equation. And but let's talk a little bit more about barriers and motivators, because I think this is just really important we have in our mind. I think this issue of motivation is really important because we're not always motivated to do anything. Ambivalence, this varying levels of motivation, is normal. We're motivated to do some things some of the time. And we're rarely motivated to do something all the time. And that includes medicine, I think, right? We wish it were not the case. But I think in real life, it is. Motivation is affected by a lot of different things. Our interactions with people, our past experiences, our expectations. And so this is a level that varies depending on what we're doing and where we're at. Now, some of the motivators, things that drive us to really be interested, include this issue of relationships, expectation, cognitive interest. We're really interested in medicine. Personal advancement is a big one, right? They should be motivated because they're going to be doctors someday. They're going to need to use this stuff, right? So I think these are clearly motivators. But there are a whole bunch of barriers to this, right? Not everybody is motivated for everything. I remember on pediatrics, for instance, I was less than motivated, I have to say. And I think you can look back at your med student careers and think about a lot of rotations where you were like that. But other responsibilities, other barriers can get in the way. And I think it's our job as educator, maybe in part, to minimize those barriers and to highlight the rewards of learning in a particular site or situation. This is what we want to do, is maximize these motivators. Okay? So what I would like to do now is to shift a little bit and talk about motivational interviewing, because I think this is a way that can inform what we do with students. Because the stuff that we were talking about, this behavioral motivators and barriers, is all old school psychology stuff. Reward and punishment. That's classical, it's conditioning, basically, right? But it doesn't fully explain motivation for learning. Other factors are involved in this, and I think recent thinking in psychology is focused on internal motivation and this change process. And we've done the most with lifestyle issues, smoking, alcohol, weight, and this has come into medicine in a big way through this health behavior model, the trans-theoretical model or the stages of change model that many of you may be familiar with. A couple of folks developed this at Rutgers, and it describes a pathway of stages and tasks that people have to accomplish internally before they change their behavior. And remember, this is used for people who are trying to quit drinking, mainly. And these are the stages that people go through. They start out pre-contemplative, they're not really interested. They start thinking, maybe I should change. They move to start preparing and taking action, and then they go into the maintenance phase where they're maintaining a particular behavior. And although this is used primarily for lifestyle issues, I think it can also describe a little bit of the process of learners as they go through our medical school rotations. So in the pre-contemplation phase, a learner might start an OB rotation and say, I'm just not interested in this. This doesn't have any relevance for me. They don't see this as being important. But then they start delivering babies and see it's better than they thought. Maybe I should study some of this stuff. They're contemplating, maybe I should be a motivated learner. And then maybe they start preparing. Well, I got to study anyway. I'll buy first aid. Okay? And then they take action where they actually stay late to scrub in on the C-section. Okay? So you can see this motivation is increasing. This is a process that I see happening in learners. And then the maintenance phase. Hopefully they had a good experience on OB, and then they realize, hey, surgery's coming up next. I wonder what I can learn there. So instead of being a demotivated or unmotivated learner, you are able to maintain a certain level of motivation that carries through across clerkships. So I think this is what we should aspire to, and I think we can help learners to move through these stages in the same way we can help patients move through the stages for their behavior change. A lot of this is based on these theories, psychological theories, and I would just mention a couple to give you a flavor for it, because this is how we can help people move along the stages. Self-perception theory is big, this one on the left. This idea that it's much more important that people think about themselves a certain way than we think about them in a certain way. So if people hear themselves saying they're going to do something, they think they can and they will do it. We can try this, but it's much better for the change to come from within. And this idea is that we should be eliciting motivation instead of imposing it. I think it's easy for us, as educators to fall back into this habit as you got to do this and we're going to require this. But it's much better generally if you want to maintain a behavior change to elicit that motivation from the learner themselves and not impose it. This is not always easy to do. But this is the idea. And another principle is cognitive dissonance, which is this idea that people hold incompatible beliefs. They're very uncomfortable about it. It forces this change process. And our role of highlighting discrepancies can cause dissonance. So on the one hand, you want to go into optho. On the other hand, you're not actually working hard on this rotation. What are we going to do to deal with it? You wouldn't phrase it exactly like that. But this is the idea of getting dissonance to drive behavior change. Okay? So this is motivational interviewing. This is MI, basically. I'm certainly not an expert in this, but I'm interested in it, and I think it is useful to think about for this process because it's client-centered or learner-centered in our case. It is directive. The educator or physician would help direct. It enhances intrinsic motivation, which is more powerful than extrinsic, by exploring and resolving ambivalence. Okay? And so I wonder if this approach might help. Now, we're not actually going to do an MI session with our students, I don't think. But I think incorporating some of these principles could be useful. And the other way to think about it is the MI spirit. And Antoine likes to show this slide. We're not actually going to do all these MI techniques that we might with a patient, but just to have the spirit of this. And the spirit is one of collaboration, that we're working together with these individuals. So we're evoking or trying to elicit this implicit motivation. We're trying to bring it out of the learner. That we respect their autonomy and support them in their change process to become motivated learners. I think if we take up these philosophies, if you will, and get this spirit, then we can be more effective at motivating our learners to excel. All right. So we've talked about teacher-learner, motivator barrier. We've talked about how MI could inform this process. Now I want to get to the money slide, which is putting it all together and the strategies that are at work here. So when I was doing the slide set, I was thinking, like, if there's one slide you should pay attention to, it would be this one. Because this summarizes, see how that heightened everybody's attention? That was really good. I'm going to use that. These are the basic approaches that I think build on this MI philosophy. And a lot of these are very similar to things that we already do, and some of it is just worded in a way that is consistent with this motivational interviewing approach. The first, of course, is always building rapport and setting expectations. A big part is modeling and setting a good example. And then we talked a lot about strengthening commitment. So this is like change talk or commitment talk. Which includes appealing to their interests, a sense of attribution. We'll talk about these all in turn. This cognitive dissonance stuff, arousing conflicting thoughts, it heightens their motivation and interest in learning as well. And then this last one, rolling with resistance. When we get pushback from students, how do we handle it? So I want to talk about these in turn, and then we'll try to apply them a little bit. building rapport should be obvious. We need to know the name of our learner, right? You know, it's amazing how many people actually don't even know the name of the student that they're working with. So this is an example of something where I think even in a one-shot clinic, we have to do this. And then even better, learning about their experiences, their goals, where they're at. This ORS thing is a technique that's used in motivational interviewing that I've actually tried to use with medical students to build this rapport and elicit some of this stuff. Starting with open-ended, tell me about yourself, and you know, where do you see yourself going? We do this kind of stuff anyway. Affirmations, wow, it's really hard studying for the boards. I'm really glad you got through it. Reflective listening, so you feel like maybe you may want to go into this, and you're thinking this will be a challenge for you going forward. Certain kinds of statements that could be useful, and then summarizing. So let me see if I have this straight. You're thinking about medicine. You really want to stay on the East Coast, whatever. So I think this helps to build rapport. We want to respect the learner values and goals and truly respect it. Like if they say they want to go into ortho, we shouldn't make any jokes about ortho, you know? This is how to build rapport with our learners, okay? Now, second is setting clear expectations, which I think this is good teaching. We should do this. Delineating specific duties and assignments helps to motivate people because they feel they have now a role on the team. We give them responsibility, and we hold them accountable. We give them feedback on what they do. This is the basic teaching process, and this helps to motivate people. It's the students who are shadowing, who are stuck in the corner of a room, who have no role. Why should they be motivated to learn in that kind of a learning environment? So this is something that I think is clearly important. Setting a good example, this is an easy one. I think we can do this, but this is, you know, if you look at social learning theory, this is how people really learn what it is like to be a physician, is they look at other physicians. And so if you treat people badly, if you're not motivated, then they will see that, and then they will adopt those mannerisms and behaviors. We treat people well. We show how much passion we have. And we treat learners as colleagues because they are our colleagues. And if we do that, I think they're going to be more motivated. All right, now these next three are commitment, right? Getting them to commit to learning. And I think this one of self-interest promotion, rewarding them, this is what it all comes down to, right? What's in it for me, right? And so I think we should capitalize on that. Well, what's in it for you? You want to do this with your life. How will, you know, working with me in clinic or going on rounds with these kind of patients, how will this help you to get where you want to go? And usually there's some tie-in or some important thing, right? Some of it may be, maybe they do have someone in their family who has Huntington's disease. But maybe that should inspire them to want to learn. And often it comes down to, you got to do it, otherwise you're going to get a bad grade on this rotation. Right? And that actually does appeal to their self-interest. I think this should be down further, right? We want to do some of this other stuff first. But I think sometimes it does come down to your grade is on the line here. Attribution is another way to help this commitment for the learner. This idea of locus of control, that they can do it, right? That they have the power to make things happen, that if they put in effort, that they will have success. I think a lot of times in medicine, it's actually not like that. You don't feel like there's any connection with the amount of work you put in and what grade you get at the end or how much you learn on that rotation. We need to diminish the role of luck and circumstance. It's not about what team you're on. It's about what you do on that team that will help you to learn. So supporting self-efficacy. This is a basic pillar of motivational interviewing, and I think it works for motivating learners as well. You can do it. Wow, so you really have. You did surgery. You survived. You can do OB too, or whatever. Emphasizing learner progression. This is an interesting one, I thought. It's instead of saying, you're the weakest student on the rotation, which is not motivating or helpful, learner progression should be emphasized. This idea that when you started on the rotation, you were having trouble with interviewing, and you put in a lot of work, and you really honed your skills. So now you're in a much better place, and you can handle these much tougher patients, or whatever. So I think this is a useful way. Attribution enhances this commitment. And then the learning menu, which I won't talk much about, but this idea that if you give learners different ways to learn, they will be more motivated to learn in that way. And this supports self-efficacy again, different kinds of learners. I found out I had a parent-teacher conference with my 11-year-old daughter last night. I was telling Roseanne. And I found out that she is a physical learner, which is really interesting. So I'm going to have to redecorate my house now to maximize learning for her. I don't know. OK. So another approach that we talked about is arousing conflicting thoughts in the learner. And this is something that ties back to this cognitive dissonance issue. And I think this is part of the Socratic questioning model. We sort of get them to think through the use of questioning and raise conflicts, issues that they may struggle with. So this is a woman with bleeding in the 3rd trimester. It's her first pregnancy. Should we bring her in, or can this be managed as an outpatient? What do you think? Trying to, well, if you don't bring her in and she has a whatever, trying to get them to really think and deal with this in a more intense way. This some people say playing devil's advocate. But you don't want to do too much dissonance because it can be a little disruptive if you hit them too hard. This cartoon, you may not be able to see it. My desire to be well informed is currently at odds with my desire to remain sane. So you don't want to really throw people off too much with this. And then the resistance issue. So this is something that I see. So you probably had this experience with medical students. When you try to set expectations, hold them to be accountable for this, to emphasize its personal responsibility, sometimes they fight back, right? They give you bad feedback on an eval. They're end-arounds. They'll go to Dean Harvey and say they were mean to me on that rotation or whatever. And so I think we have to be able to roll with this. So in the MI framework, we can't get defensive. We can't get angry at them. That's not going to help. And I think we know this. We know that doesn't really help. We have to be able to roll with this and hold our ground and really try to engage with the learner as best we can. All right. So those are the big strategies that I think, this is not rocket science. Most of you are familiar with these sorts of things. But what I try to do is frame it with this model of MI that hopefully gives it this background. And what I want to do now is apply these principles to a couple of cases just to try this out a little bit. And so the first one, let's see if this works here. Anybody ever see My Fair Lady? It's like one of my favorite movies. Love it. And I use it often as a demonstration of different teaching methods, usually bad teaching methods. But there is one scene in here that I really kind of liked. And so I want to show this to you just for a minute. And we get sound. Oh, man. Oh, it's such a good scene. But is there anything coming out? Oh, technical. I'm sorry. Does any? Okay. So he's saying, you're not going to make me do this, are you? I think I'm going to have to skip this. But the gist of it basically is that, she's worn down by all this teaching. She's demotivated and doesn't seem to be making any progress. And he is saying to her, after much stress and anguish, he's saying, now come on now. Remember why you got in this in the first place. You wanted to be a girl in the flower shop. The English language is so important for you to learn. This is going to help you to achieve these goals that you set out for yourself. It's the most beautiful language in the world. And he goes on with this passion about what he's teaching. And you can do it. I know you're tired, but I know that you can do it. And this is so important. Let's try. And you remember what happens after this? The rain in Spain stays. She finally gets it, thanks to this teacher intervention that really paid off. So go Henry Higgins. And so what I was going to do after you watched all that was to show you these skills, just to remind you, the things that he did in order to be effective at motivating his learner. He built a rapport with her. He shows that he actually cares. He's not such a mean guy. He's very good about setting expectations. That's probably too strong there. But he's also setting a good example, modeling the speech that he wants her to learn, strengthen the commitment by appealing to interests, attribution, that she can do this. He does not do this, right? You've got to learn it my way or else. So that's not a strength. And he rolls with resistance. So there are some things, you're not going to do everything with every learner. But I think incorporating some of these principles, some of them may be more comfortable with, can make a difference. Well, let's, without technology, go back to this case, right, that I brought up at the beginning. And this is the case of the learner who didn't want to interview the patient. So let's talk about this. What's going on? What might you do? What kind of things would you do with this learner? Let's focus on that. Yeah?
I think you might point out to them why this is an interesting patient and what sort of knowledge and skills they can gain by going and doing the patient.
Right. So this is part of showing that passion, also getting them to a place where they could really connect with the material. Yeah?
Well, the first question's got to be why not? Because then if it's, like, I got my kid at daycare 10 minutes, you're licked and you may as well let him go,
Yep.
But if there's some other reason that you can roll with, then it's different.
Right. So that gets to the point of the differential diagnosis and how important it is for us to assess what's going on with this learner right now. Because if they are in that place where they're just not going to learn, you got to give them a pass. I mean, you got to let it go and then come back tomorrow or whatever when they had a good night's sleep. I think that's pretty clear. Other thoughts? Yeah.
The questioning part, like, what will happen to this patient if you go?
Okay. All right. And what's going on using the questioning approach to raise issues? Because, and this could help get at your point as well, like what could be going on? Is this a serious issue? How could this affect her? And why is this something that we're really excited about? Yeah.
Do a menu of options. Say, do you want to collect the history of present illness? Do you want to collect the rest of the history, or do you want to do physical exam?
There you go. Yeah. Do you want to help by looking up the records on the computer? Do you want to call the family members and find out what we know about the movements? I think giving them a menu of options, we may find, because not every learner is really excited about the interview, but they may be more excited to look at the MRI. Actually, this particular learner, I think, would have been much more excited to look at the MRI. And so, this is good. We can tap into that.
But Jason, you think it's important for her to see this patient, correct?
Yes.
Why are we going to let her opt out? After we do all the things about daycare and those kind of things, say it's 10 o'clock in the morning, and there's really no reason why this person should opt out because of time constraints, and I doubt many people are on call enough that now fatigue would get in the way with many things. So let's just pretend that she is not, you don't know why she's going to do it, but there's no other reason other than don't want to do it. I mean, could we talk a little bit about that? Because I think that's what bothers most of us.
You have an idea?
But I do this with my daughters. Do you want to do this? And the answer should be yes, right? Like there is
Well, you don't ask the question.
Right.
Exactly.
Sometimes I'm like,
Yeah.
sorry, let me rephrase.
Yeah.
Let's go see this patient.
Yes. So I think it depends a little bit on the situation in terms of how strongly you're going to push for that. So with this particular student, it was the first day in clinic, right? And so in the first day, I usually don't push. Some students are really raring to go. Others hang back. So you give some flexibility on that. But if it were their third day with me, then I would be more likely to say, okay, I want you to do the interview. Let's just go for it. And whether they're tired or they got childcare stuff, they're gonna be pushed to do it. So I think you're right. It's situational. Yeah.
I think along the lines of what you said in terms of trying to figure out what's the differential diagnosis here, to the extent that you can act very sympathetic and very concerned, like, this is a big deal. I know you would never say no if there wasn't something horrible going on. I mean, not in a ridiculously dramatic way, but reacting that way allows you to stay on their team, you know, so that you don't create this adversarial relationship, but it also gives them signals about professionalism that I think are important. If they don't get the data that any normal medical student who didn't have something really awful going on would of course have said yes to this. So therefore, since you said no, there must be something awful going on. That's giving them data that they need.
Yeah. It sets expectations. It's
Easy
helpful.
way to give feedback, yeah. Any normal medical student would want to see this patient and say, what is wrong with you?
We have to find a nice way to phrase that.
Well, I think this is a key that I've been thinking about, because we say we know more than they do, so we have to take charge. On the other hand, the student very often has their own idea of what they need,
Yeah, that's right.
and they don't always match.
Yes, that's true.
I remember being in a talk with people in the mechanism of action of antimicrobials, and one came up to me and said, I don't want all this stuff. All I want to know is how much you give and when.
Yes, that's right. That's right. Yeah, and so you have to decide how much do you force it. Yeah.
Do you think there would be a role in cautiously highlighting the unconscious incompetence by saying, like, you know, for instance, do you think there's a particular reason I'm asking this patient? Because you don't want to come out and say this patient probably has a unique diagnosis. Then that kind of defeats the whole learning purpose. I think this patient has cholera.
Yeah.
You know, but just say, you know, why do you think I'm asking this patient as a routine patient, or do you think I'm at least letting them maybe know that there's
Yeah.
a hidden learning objective for that to discover.
Absolutely.
What
And
are your thoughts on that?
I absolutely think that's true. And so questioning could elicit this a little bit. Questioning could bring it out. It highlights some of the dissonance. So they want to give up, but then they're also tension because there's this expectation. There may be a hidden secret in this case, and it leads to tension that might inspire them to learn. Yeah.
Because I'm concerned about the concept of this is a really interesting case, so you need to be motivated now, because not every case is interesting.
Yeah.
And so if you motivate them with the idea that, okay, this is a real interesting thing, you should really want to do this, you may set up the expectation that if it's not an interesting case, or if you've seen this before, then you really don't need to care. Now, people keep talking about bringing your A game, and you know, I'm not even sure I have an A game. I'm sure I don't bring it every day, but you have to bring your B game.
Yes.
You can't bring your F game.
Yes.
And so, you know, this is a bad day for you. I'm sorry to hear that, but you know, this is the expectation.
Yes.
There's just some things there that, you know, if you make this, well, this is a great case, so you should really want to see this patient. Well, you know, they're not all great cases.
You're right.
Well, yeah, you have to go back to that sort of diagnose what's going on, you know, and it may be, like you were saying, this is the first day, they're anxious, they don't want to jump right in, they want to go read the chart first or something like that. And so, you know, you go, and then you have to think, what do you want them to get out of it? Okay, so if it's a Huntington's case, they're going to have Huntington's tomorrow, right? So, okay, so is there, you know, figure it out, and if it's, I want to see the MRI and the chart and all that stuff first. Okay, go ahead and do that, but you still need to come back and see this person. And then, what I try to emphasize with them all the time is this will be on the boards. You know,
Yeah.
I go to the national board, I promise you this will be on the boards. Right? You need to know this stuff.
Yes.
And that usually gives them a good push.
Yes. Yeah.
Is there any data on the effect of culture and background on the change and the process of change? Because I think it depends. Certain people come from a certain culture where it's a little bit more, I guess for lack of a better word, dictatorial, and they're kind of used to it.
Yeah.
And then they're surprised when someone gives them this menu of options.
Yeah.
Now, I myself, for example, with a group of students, I said, oh, that's a great question. I'll look that up for you guys. And one of the medical students said, Dr. Jasny, you're not supposed to say that. You're supposed to say, you look it up. And you'll come back the next day.
That's
That's
right.
a good idea.
Yeah. it's a really interesting point that you raise about whether different learners have different styles, and I think we know that they do. But let me come at this question from the MI perspective. So with this motivational interviewing stuff, looking at patient behavior change, you think that maybe some patients would respond to the more directive, you need to quit smoking. And there are some patients who do, but it's like 10% or less. And everybody else really does, bristles at that. They resist that approach. So in some cultures, that 10% may be 15% or maybe 20%, but it's never more than half in the different places it's been looked at. And I think it's the same with learners as well in terms of their motivation to learn, that the more directive, lecture-based, you got to do it approach doesn't resonate with the majority of learners. And as we were talking about in Kazakhstan, the traditional model of medical education, which is 1,000 students sitting in a lecture being taught to, and you've got to do this. And the quality of the physicians that come out of that kind of a learning environment is really not so good. So I think there may be some differences, but not major enough. We still need to focus on this kind of approach of eliciting motivation from the learner. Do you have a thought, Tom?
So what do you do when it's a sophisticated learner, like a senior resident, and it's a boring, uninteresting experience?
Yeah, so I think part of it is what you were saying, Dr. Painter, that you have to say there's a basic level of competence and activity that you have to do and set that expectation. The senior resident will have a responsibility that's a higher level than a medical student learner, and they've got to do that, and giving them that responsibility will hopefully make them do it. There are other things, of course, adapting the teaching points that come out of a particular case and tailoring it to that learner's level and interests, and trying to do that, I think, will maximize the motivation. Does that make sense? I think this is what we do. Well, let's see how we did. Let's look at this in terms of some of these strategies. For this learner, one of the other things that I did was really focus on building rapport and showing that I care about the student. We've touched on this, but I think one of the problems with my particular student was that we threw him in without any opportunity to find out who he was because we were rushed. And we had, this was like the first case of our day, and I had no idea who he was or what he was interested in. It was like, see this patient, and so I think we spent time later that afternoon, finding out who this person was and what they wanted to do, and getting to know a little bit about his background, and that's when I found out, for instance, that it was his first rotation as a third year. So I think this stuff is really important. We talked about expectations, which I hadn't done in advance. So I actually said to him, interviewing patients is the expectation in this clinic, because he was used to and expecting to shadow, which was his experience in previous CE stuff. So that was pretty clear, and I think that helped for future encounters. I tried to set a good example, and this was, in part modeling my passion for this and every case, right? I'm excited about it. Even the garden variety depressions I see, I try to be. And so, and then strengthening commitment. So one of this was appealing to his interest in radiology, and let's look at the MRI. The learning menu, so that was we touched on. Questioning, and I rolled with the resistance. Although I was really upset, right, at this apparent lack of motivation, I didn't get defensive or angry. I said, okay, well, we need to talk about this more. And then I think that helped, because otherwise we could have gotten into a conflictual relationship that would have been counterproductive, I think. So
that moment when he said that to you, that immediate moment.
I said, okay. Are you sure? I think I said something like that. Are you sure? This is a great case to talk. But when he said no, I didn't push it any further and said, okay, I'll interview. You watch. We'll talk about it after. And then I think we still got something out of it. Yeah.
I think there is an awkward transition for our students too in moving from shadowing to an active learning. And sometimes they feel that they don't want to slow you down. You have X number of patients to see. If I take charge of this patient or this interview, it'll slow us down by a half hour today. So it's a real fine line of how aggressive can I be as a student, as a learner, and how much am I impeding the regular flow of what would happen.
Yes, yeah, that is an issue. And we've been talking about clinical rotations, but I just wanted to throw out the idea of first and second year students. So in the preclinical years, can we do this stuff with preclinical students sitting in an anatomy lecture, or what do you think? Or is this really less relevant? Less relevant?
No.
No, you think it's just as relevant. Okay. Any adaptations for preclinical learners you might consider? Because we can't get to know every single person in that class, right? I guess we do break them out in small groups. So the small group facilitator might be able to get to know them and show they care. We can answer email or whatever questions. I suppose we could do those sorts of things. Any other thoughts?
I would say as far as transitioning this into a big lecture hall situation, maybe that building rapport, showing care, the best thing you can realize is the level of learning of your audience. What's their background? What courses have they had before? Have they had a lecture on drug XYZ before, or is this the first time they're seeing it? Because you're coming in with a knowledge level that's so far above them, and you want to get into all that interesting stuff. Maybe they don't even have the foundation.
Yes.
Grasp what you're saying. So that building rapport is taking the time to look and see what material has been in the curriculum before you are introducing content.
Yes. Another big thing I know that is done in the preclinical is this appeal to future interests. And some of that is the board exam. But also, that learning these pathways will help you to understand mechanisms of drugs that you're going to use in your daily practice down the road or whatever. Trying to tie basic science with clinical care. We certainly are doing a lot of this stuff as well, and rolling with a lot of resistance in the first 2 years.
What about the dissonance? You skipped over that.
Yeah, what do you think? How do we create dissonance in first and second year med students? I struggled with this. In my psych course, I wanted to do a debate format. Talk about DSM, is this a good thing or not a good thing? And a lot of people in my department were very reluctant to create that much tension in the room. That it would be too disruptive. People would get too upset or discouraged about the state of our field. But I think there might be other ways of doing it that, I don't know, what do you think? Can we create dissonance in preclinical? There you go. Yeah. See.
Reality checker. You think that you're learning this, and maybe you're not.
Yes, that's true.
I think it depends again on the situation. You brought up the example of maybe a senior resident with a routine case. That might be the best time to use something like dissonance to kind of show that there's still more to learn.
Yes.
Like, okay, you can then try to say, but hypothetically, what if the patient then had an allergy to this drug? What would you use next? Or
Excellent.
they're Jehovah's Witness, you can't do this surgery. What would you do? Whatever the case might be. I think that's where it's better for more advanced learning to continue to challenge and show that there's still more to learn.
Yes, that's good. So I think these strategies can be applied across different settings, and that's why I wanted to share them with you. There are a couple of other points I want to make, and then we can open up to more discussion. We've talked about the barriers here, the differential diagnosis, and I just want to comment on these two issues, teacher inefficacy and learner impairment. I couldn't think of a better way to describe teacher inefficacy. I don't know, I couldn't think of a better term for it. But I think if these are factors, then we need to get help, right? And so if we are sensing that we have skill deficits, we don't know how to do this creating dissonance, or Socratic questioning is not a strength of ours, then we can actually talk about it. I think the most common way we get help is we're stuck with a student. There's a student who comes in and they're just not getting it, or they're really not progressing, and we don't know what to do. I think we should ask for help, right? Get a colleague, a supervisor, somebody to say, this is the situation, what can I do? Group supervision. In my department, we do a lot of group supervision around teaching. I think this is really useful. Now, the other side is learner impairment. So I think one of the issues with a lot of learners who appear unmotivated is that they are actually depressed, right? They are struggling because they're burned out or something. Something's going on, right, that they are not processing. And that may be why they appear to be unmotivated. They need help. So we refer them for help. We try to get them treatment. And I think this helps to get learners better. And this same thing for personality issues. Getting help, I think, could be useful. And the last thing I want to address is challenges in this process, and come back to some of the things that Dr. Painter was saying. We ultimately grade the students on their performance. This is really important. We don't give them a pass, right? If they were really unmotivated and never stepped up to the plate, we cannot excuse poor performance just because they're uninterested. We don't lower standards. If they deserve an unsatisfactory because of their performance, then we give them that, right? So I think this is really important, and I wouldn't want to go any other way. And I also want to acknowledge that there are risks with this, right? There are downsides to the kind of approach that I'm talking about. It certainly takes time. So like in my clinic, I had to carve out time at the end to talk to the student and get to know them and all that stuff. It takes a little time. But I could still get hammered on evals. The student could say that I was picking on him or I was making him do stuff before he was ready. That's a risk. I might have misdiagnosed it. You know, maybe he actually has Asperger's or something, and that's why he came across that way, and I just missed it. And some students just are never interested, and there's nothing we can do that's going to get them interested in what we do, what we teach. Like those privacy security things. No amount of these skill sets is going to help UPMC make me motivated to take one of those training modules. But we still have to try.
That's why they give you a $1,000 fine.
That's right. I suppose that's a motivator. Yes, yes. I think it is worth it. You know, so taking the time to work with a student, I think I enjoy the relationship actually. So that is satisfying to me. But more than that, taking time to set those expectations in the beginning makes everything easier the rest of the rotation, because then they know what they're supposed to do. They feel they have this responsibility. It gets them from their C game to their A game faster. So I think it's a little investment, but it works and pays off in spades as we go. So final thoughts. I think we got to recognize that learners are ambivalent frequently about their level of motivation for a particular area. If they appear unmotivated, do this differential. Like, what's going on? Is it me? Is it them? What are the barriers here? Consider both teacher and learner factors. Our job as educators is to try to increase motivators, decrease barriers as best we can. And using this MI spirit and some of these high-yield strategies, I think, can activate intrinsic motivation, which is much more powerful than just telling them that they need to do it. If we get stuck, we get help, and then I think we can have better outcomes. All right. Questions, comments, discussion?